Glaucoma is a broad topic that includes more than one type or cause. The best place to start in discussing glaucoma is with a definition for glaucoma. Glaucoma is a progressive optic neuropathy that is caused by an intraocular pressure that is too high for an individual's optic nerve. The pressure that can be tolerated can be different for different patients. Some patients have normal tension glaucoma, a condition in which the intraocular pressure measures within the expected range, but the patient's optic nerve suffers glaucomatous damage. Ocular hypertension is a condition in which the intraocular pressure is higher than expected, but with no nerve damage. The treatment of glaucoma is focused with lowering the intraocular pressure, either by decreasing production of aqueous fluid or by increasing outflow. To better understand glaucoma, let's examine the aqueous humor pathway. The aqueous humor is produced in the posterior chamber by the ciliary body, specifically the non-pigmented epithelium of the ciliary body. The fluid then travels through the posterior chamber, around the pupil, and into the anterior chamber. The fluid then makes its way out of the anterior chamber in the eye by two pathways, trabecular outflow and uveoscleral outflow. About 90% of the aqueous outflow is via the trabecular pathway, through the trabecular meshwork into Schlimm's canal, and then into the episcleral venous circulation. About 10% of the outflow is via the uveoscleral pathway, with aqueous fluid absorbed directly by the iris and sclera. Glaucoma is divided into two major types, open angle and closed angle. Open angle glaucoma refers to glaucoma in which the anatomical angle, the area where the cornea and iris seem to come together, is open. This tends to be chronic, largely asymptomatic, and painless. Open-angle glaucoma can be primary, meaning no cause is identified, or secondary, meaning a cause can be identified, like intraocular inflammation, intraocular bleeding, or pigment clogging the trabecular meshwork. Closed-angle glaucoma refers to glaucoma in which the anatomical angle is obstructed, and the aqueous humor is prevented from flowing through the trabecular meshwork. When the lens iris diaphragm is shifted forward, it obstructs the normal aqueous outflow. The aqueous builds up behind the iris and pushes it forward, fully obstructing the angle. This is often acute in onset, extremely painful, associated with acute vision loss, and is a true emergency. In acute angle closure glaucoma, the patient typically has a fixed, mid-dilated pupil. Closed-angle glaucoma is more common in hyperopic eyes. Remember, those eyes are too short, and as a result, the angle is often crowded. Mydriatics, medicines that dilate the pupil, colloquially referred to as dilating drops, are contraindicated in individuals with anatomically narrow angles. A less common cause of angle closure glaucoma is neovascular glaucoma. In an ischemic eye from diabetes or internal carotid artery disease, tissues release VEGF. This can result in new vessels growing on the iris, a condition called rubeosis. These new blood vessels can obstruct the trabecular meshwork. Regardless of the cause, there are characteristic optic nerve changes that can be seen across the entire glaucoma spectrum. The cup-to-disc ratio of the optic disc is increased, a condition known as cupping. As stated before, the primary goal of treatment is to decrease the intraocular pressure. This can be done by decreasing aqueous production or increasing outflow, and this can be accomplished with medicine or surgery. Beta blockers, alpha agonists, and carbonic anhydrase inhibitors decrease aqueous production. Prostaglandin analogs increase outflow via the uveoscleral pathway. Surgically, a shunt can be placed in the eye to facilitate aqueous outflow, or an endoscopic laser can be used to destroy part of the ciliary body in order to decrease aqueous production. Acute angle closure glaucoma is treated with osmotic diuretics and a laser procedure known as a laser peripheral iridotomy, or LPI. This procedure creates a full-thickness hole in the peripheral iris to allow fluid trapped in the posterior chamber to escape into the anterior chamber and allow the iris to recede back to its normal anatomical position.